So, hello everyone, welcome back to my channel. Today my video is going to be based on the cholinergic antagonist. In the previous video, I have discussed about the cholinereceptors and the cholinergic neurotransmission. So, let's get started about the cholinergic antagonist. If you remember, the cholinergic agonist, if you talk about an agonist, it basically stimulates the acetylcholine receptor, which is the most common in our body. But if we talk about the antagonist, they do the opposite. They prevent the effect of the acetylcholine. So what a cholinergic antagonist does is that this antagonist binds to the cholinereceptors, the muscarinic receptor and the nicotinic receptors. Cholinereceptors are of two types. Muscarinic, we call it MR, and nicotinic receptor, we can call it NR. I have explained these two cholinereceptors elaborately, like very briefly, in my previous video. You can watch that if you want to have a review about that. Now, if we talk about the clinical use of cholinergic antagonist, they selectively blocks the muscarinic receptors, so we can have like muscle relaxation during surgery, or we will discuss many more clinical uses in this video. So the most common agents that belong to this cholinergic antagonist are the antimuscarinic agents, which act on the muscarinic receptors and blocks them. Another agent we have is the neuromuscular blockers. Neuromuscular blockers, the most widely that is still used in clinical practice is the succinylcholine. The third one is the ganglionic blockers, and the only one that belongs to the ganglionic blockers is the not the nicotinic receptor, basically the nicotine. We will discuss about that in this video. So first we will start with the muscarinic agents. They are also known as the anticholinergic drugs. They basically blocks the muscarinic receptor and thus inhibiting the muscarinic function. In addition, I would say that these drugs blocks few exceptional sympathetic neurons that are cholinergic too, such as those are the salivary glands and the sweat glands. Yes, I'm talking about the antimuscarinic agents. Now, for the antimuscarinic agents, they have no effect at all at the nicotinic receptors. Like, they do not block the nicotinic receptors. Now, as they do not block the nicotinic receptors, so they have no effect, no action at all at skeletal neuromuscular junctions or the autonomic ganglia. So the anticholinergic drugs, that are the antimuscarinic agents, they are beneficial in a variety of clinical situations. We can use at antihistamines and antidepressants also have this activity. Now, the most common agent that belongs to this antimuscarinic agent is the atropine. That is well known, and it has it is not used in the clinical practice as much as other drugs, because many other drugs have replaced atropine, because it acts on, like, it has variety of action. So in today's clinical practice, many drugs have replaced this atropine, but it's still used as an antidote for many other drugs. Like, for example, in organophosphate poisoning, the most common drug we use is the atropine to overcome the effect. Okay, so there are many features for this atropine. First, we will discuss that it has high affinity for the muscarinic receptors. Obviously, it belongs to the antimuscarinic agents. It binds to this and prevents the acetylcholine from binding. The action lasts for about 4 hours. Effects are both centrally and peripherally. Now, if we talk about the atropine, the sites of actions, they are the heart, GI, salivary glands, sweat glands, also lacrimal glands that are associated with the tears, the eye. It is widely used in eye in ophthalmology. Now, if we talk about the GI, it basically blocks the N3 receptor, resulting in the decreased GI motility, prolonged gastric emptying. Although the gastric motility is reduced here, but the hydrochloric acid production is still not affected. Thus, we cannot use atropine for the treatment of ulcers. The doses of atropine that reduces spasm also reduces the saliva secretion and also decreases urination. If we talk about the uses of atropine in the salivary, sweat, and lacrimal glands, if you use it, they leads to dry mouth, dry skin, and increase in temperature, hyperthermia. Now here, the site of action at the heart, it blocks the N2 receptor at SA node and AV node. This will eventually lead to tachycardia, but this will only increase the 30 to 40 beats per minute. It will lead to increase in heart rate, decrease in the BP. So what basically happens at the heart side, at low doses, it slightly decreases the heart rate because of the blockage at the M1 receptor, but at high doses it blocks the M2 receptor and increases the heart rate, causes tachycardia, but the only increase in heart rate is about 30 to 40 beats per minute. Here, the salivary glands are very sensitive to atropine. They block the muscarinic receptor, leading to the dryness of the mouth, also known as the xerostomia. Yes, I know I'm repeating it, but that's pretty useful, and once you repeat things, you get to learn better. Now, if we talk about the uses or the clinical practice, if we use it today, the atropine is widely used in ophthalmology. How? You can see it can cause the cerebral muscle relaxation, dilation of the pupil, also known as the mydriasis. It can also be used in the cycloplegia, visual focus, to improve the visual dilation of the pupil, inability to focus near vision, that is the cycloplegia. In patients with angle closure glaucoma, intraocular pressure may rise dangerously. So this drug is contraindicated with the patients who are suffering from angle closure glaucoma. This will lead to intraocular pressure, increased rise in the intraocular pressure very dangerously. So this is contraindicated in glaucoma. It has increased effect on glands and eyes. The antidotes that can be used to overcome the effect of the atropine are the physostigmine. These are the muscarinic receptor antagonists. They love the muscarinic receptor, also known as the competitive antagonist. Increased dose will cause the decrease in the BP, and decreased dose will have no effect. Now, in what factors these are indicated? In the septic shock, bradycardia, and ocular OP. I forgot almost. Yeah, so where were we? We were describing the clinical uses of atropine in ophthalmology. This also treat inflammatory conditions. This can be used before the surgery because it has longer duration of action, so other drugs are used in place of the atropine these days. That are the cyclopentolate and the tropicamide. Let me repeat, cyclopentolate and tropicamide. Their duration of action lasts for this is much shorter than the atropine. Atropine is used in the ophthalmic solution. For mydriasis, it is used in the ophthalmic solution. Here, because of the longer duration of actions, atropine has been replaced by the cyclopentolate and tropicamide, because the only difference between the cyclopentolate and tropicamide is that this is the long-acting muscarinic agent and this is the short-acting muscarinic agent. Its effect lasts for only 6 hours, whereas the cyclopentolate, its duration of action is still for 24 hours. Atropine also has many adverse effects. Depending on the dose, atropine may cause dry mouth, blurred vision, sandy eyes, tachycardia, urinary retention, constipation, and so on. Effect on the central nervous system includes restlessness, confusion. Later on, I'll give you mnemonics in order to learn the side effects that are almost the same of all the cholinergic antagonists. So let's move on to the second drug that belongs to the antimuscarinic agent, is the scopolamine. So basically, scopolamine is a tertiary amine and it has a greater action on the central nervous system and a longer duration of action than atropine because it enters the CNS. Now, scopolamine is one of the most effective drugs available for motion sickness and in post-operative nausea and vomiting. But it also has an unusual effect of blocking the short-term memory. Now, as compared to atropine, scopolamine produces sedation at a very high dose. And scopolamine may produce euphoria too. Now, in the clinical practice, this scopolamine can be used while treating for the motion sickness. It is available as a topical patch that provides effect for up to 3 days. As with all the drugs used for motion sickness, it is much more effective than for treating motion sickness once it occurs. So it should be at the tip of your tongue that scopolamine is used for treating the motion sickness, whereas if you talk about the atropine, it has wide uses in ophthalmology, but it is contraindicated in glaucoma. These are the key points. Master it. Now let's move on to the ipratropium and tiotropium. These are the quaternary derivatives that eventually leads to the decreased contractility of the smooth muscles. So in lungs, it can cause the bronchodilation, decreased mucus, so we can use it for the treatment of the bronchospasms. The only way to give the ipratropium and tiotropium is the inhalation. For example, in COPD patients or asthma, we can give it them through the inhalation. Only difference between ipratropium and tiotropium is again the duration of actions. These are the short acting, these are the long acting muscarinic agents, quaternary derivatives of atropine, and they do not enter the central nervous system. Now, another two muscarinic agents or the antimuscarinic agents or the muscarinic blockers I would like to mention is this benzotropine and trihexyphenidyl. The drug names always very hard to pronounce. These are the muscarinic blockers which are mostly used in the Parkinson's-like disorder and also in antipsychotic. Now, I have a good mnemonic for you. In order to learn these adverse side effects of anticholinergic drug, we have the mnemonic known as ABCDs. This is the mnemonic. For example, A is for the agitation, B for blurred vision, C for constipation and confusion, D for dry mouth, and S for stasis of urine and sweating. These are the side effects of all the agents I mentioned above: the benzotropine, trihexyphenidyl, ipratropium and tiotropium, scopolamine, and the atropine I mentioned lastly. So you can take a picture of this. It's very easy to remember the adverse side effects of anticholinergic drugs. The other drugs are also oxybutinin, darifenacin, solifenacin, and trospium. They mostly take part in the urinary retention, and all of them are mostly seen, so we won't study them individually. This is for the treatment for urinary incontinence. And so for trospium, the very basic is it crosses the central nervous system. I'm discussing the trospium because it is still used. This treats the overactive bladder in patients with dementia. We can give trospium to the patients who are suffering from Alzheimer's disease for the treatment of their overactive bladder. And at the end of the video, we will discuss certain MCQs also, so we can know which drug is suitable for which patient. So I guess that's it for today. We have discussed a lot. It's already been 13 minutes, and we will discuss the ganglionic blockers and the neuromuscular blockers in the next video. I decided to divide them into 2 parts because otherwise it will be last for maybe an hour. So thanks for watching, and if you suggest any other improvements in my video, you can mention in the comment section, and if you have any other knowledge you want to share, you can share that with me too. Okay, goodbye.